So a patient you may run into would be a patient with restrictive lungs. Now, restrictive lungs, we've got to consider this is a person who we're having issues ventilating because their lungs are extremely stiff. They're hard like rocks. It's like a bowling ball. You're trying to push air into the holes of a bowling ball. You're trying to stir a, cake batter that's so dry and stiff. Conditions that would cause this would be patients like an ARDS patient, patients with COVID pneumonias, patients with bad pulmonary contusions or pulmonary edema. All stiffens up the lungs. So how are we going to combat that with the ventilator? If you were just to start ventilation on a patient with restrictive lungs at the standard setup mode of the adaptive mode, APV CMV, it's going to give you a lot of problems to start. First, it's going to set a respiratory rate that is extremely low. Couple that with a patient whose lungs are very stiff, we're going to pressure limit very quickly, and we're not going to achieve our goal minute volume of a 70 kilogram patient of around 7 liters per minute. So what are some things that we can do to alleviate that? Well, first, we've got to realize that the patient's tidal volume goals should be between 4 and 6 mLs per kg, not 6 and 8. So if we're going to stay in the adaptive mode, we need to back that down to at least 6, but potentially much lower, closer to that 4. The problem when we do this and our respiratory rate is still low, our minute volume will typically fall. And again, in the adaptive mode, it will take 5 to 8 breaths for this to be achieved. And as we see, our minute volume drops. We have to make up for that with a much higher respiratory rate. For our restrictive patients, it may be 18 to 24 times a minute. There is another mode that you can use as well. Our pressure support modes work very well. These will provide an immediate trigger. And again, at a rate of 24, we have a very long or very short I time here. So switching the mode does not necessarily change, but it can help. As you see, our expired minute volume, our minute ventilation is now appropriate for this patient. We're getting between 4 and 6 cc's per kg tidal volume on this 70 kilogram patient. If we're having issues with oxygenation now, we can always increase our FiO2. But if we have to increase PEEP, we're going to start to hit pressure limitations at a quicker rate. Now remember, in this 70 kilo patient, 4 cc's per kg of tidal volume may be appropriate to maintain that around 7 liters per minute tidal volume. So how do you know that this patient is ARDS? Go to monitoring, tab 3, And your C static is the best measure of your compliance. 15 and below, that's an F. That is really stiff lungs. Those are the end-stage ARDS patients who are typically going for ECMO cannulation. 15 to 25, that's a D. That's something you can work with, potentially salvage and improve with your ventilator management. 25 to 35, that's a C. You can improve, that as well. Anything above 50 is of course an A, so you're in good shape there. So what are some other techniques that you can use in these patients? Well, on the ventilator alone, we can adjust our I time. By increasing our I time, it slows down the rate at which we're squeezing our bag valve ventilator. Go ahead and attach your bag valve ventilator to an ET tube. Squeeze it over a second. It doesn't generate so much pressure. Now try to squeeze that same amount with your bag valve ventilator in as quick as you can. It is a lot harder. You're going to achieve a higher pressure quicker. It's going to cause injury. It's going to cause problems unless you are like our vent and have a pressure limit. Now see, just by doing that, we increased both our tidal volume and our minute volume. Again, we already have a high respiratory rate, so respiratory rate, tidal volume equals minute volume. We could even lengthen this more. But these are the things when you have a patient who may have that C static of 15 or less. Your medical control physician, before you say, hey, I want to increase my pressure limit to 40, they're going to want to know that you have made some of these adjustments. Other patient adjustments could be sitting the patient up at 30 degrees, taking any tight constrictive bands off the chest, providing additional sedation. Typically these patients are going to be paralyzed, but pain control is absolutely critical. Those are just some techniques to use in order to get better ventilation of your patients. And again, you can do these same things with an APV-CMV mode. However, look, our TI is 0.5 seconds. The way we're going to have to achieve that is going to be adjusting the I to E ratio to the same as we had it in the PSI-MV mode. But again, we're going to have issues because it's going to take several breaths to achieve our goals. So if you have a patient that really needs their oxygen without decompensation, APV may cause some issues with that. That's why if you're having issues with APV-CMV, the protocol does encourage you to switch to the PSI-MV plus if you're having issues after those corrections.